Started. All right. So I'd like to welcome everybody to Pediatric Grand Rounds. First, a little bit of housekeeping. If folks could please click on the CME link in the meeting invite, that helps us track attendance, and also hopefully one day we can bring food back into the mix. So it would be helpful, even if you're not claiming CME credit, to be able to get that attendance information. So we do appreciate it. So today it's my great pleasure to introduce Dr. Maria Cabral. Dr. Cabral earned her Doctor of Medicine in the University of the Philippines. She then went on to pediatric residency at St. Joseph's Regional Medical Center in Paterson, New Jersey, and completed an adolescent medicine fellowship at Nicholas Children's Hospital in Miami. Currently, she's in Kalamazoo, and she is co-director of their adolescent eating disorder program, which I think is always a topical topic and definitely a changing topic. And today she is going to talk about a diagnosis about which we may not be as familiar. So it's ARFID. I'll turn it over to Dr. Cabral.
Yes, hi. Thank you so much for the kind introduction, and thank you for inviting me to your grand round. So, the next, or I guess during your lunch hour, we'll be talking about this diagnosis, and you'll hear me say ARFID a lot, which stands for Avoidant Restrictive Food Intake Disorder. So it is a mouthful, definitely, no pun intended. But when I do talk about this with parents and patients, and hopefully the next hour, you'll get some information to take away, and who knows if the next patient you see in clinic or maybe in the hospital will be an ARFID patient. So the ARFID patient is not just another picky eater. Let me go back here. So I have no disclosures whatsoever, no conflicts of interest. And so for this lunch hour, our learning objectives, as stated, we'll talk about the changes made to the DSM-5 and particularly talk about ARFID and describe the prevalence, demographics, and how they present, especially given what we currently know based on data, and talk about how we can assess these patients, treatment approaches, and hopefully, if we have time, I have a couple of cases to discuss with you that I personally cared for. So I'll start with this one. So not all picky eating is harmless, okay? So I know as pediatricians, we see this a lot as a common concern in the clinic. However, not all eating disorders look the same. So this book is actually, it's a novel about a 16-year-old girl. Her name is P. And basically it talks about how she always felt something was wrong with her, like how she eats. She's worried about textures, about smells, even how foods look to her can be frightening. And then finally, she was diagnosed with ARFID, which we have limited information available. But the hopes is with that diagnosis, it would give her the treatment that she deserves. Often with these patients, they would say just picky eating or picky eaters. So like in this book, we describe how it's as if having a monster inside of her that tells her how she should eat, what she should eat, and it really impacts how she socializes with her peers. And that it keeps growing, and it brings about anxiety and depression, and sometimes some thoughts that she doesn't want to have, and she feels alienated. So that sort of gives you a picture of the kind of patient that we'll be talking about. So the DSM-4 text revision, this is like 20 years ago now. It was mainly used again to for us to be guided as we diagnose, particularly eating disorders. And what we see here, these disorders are also classified based on age. So many of the picky eaters were thought to belong to this group, so the feeding disorders of infancy and early childhood. However, as we know, this diagnostic criteria is now obsolete. for one, when the eating disorder work group came about, they had noted some of the diagnostic challenges of those who sort of fell in this group of disorders. For one, it's actually rarely used, and there's not enough information about those affected individuals and based on characteristics, course, and outcome of these kids. And also, we're seeing similar presentations not only in kids less than age 6. We're actually seeing it even in older patients. So when the DSM-5 came out in 2013, I was a year into my fellowship then. They now have this broader umbrella term of feeding and eating disorders. And these are disorders, or I'll call them as FEDs. They are characterized by a persistent disturbance of eating or anything related behavior, which in turn would result in altering their consumption or absorption of food. And what makes it a disorder is this part, where all of what I mentioned would significantly impair their physical health and psychosocial functioning. So this is the list of the eating disorders that we know to date. And the idea is, or the goal is really to have non-psychiatrists be able to make the diagnosis, and that it can vary according to age and stage of development, with some disturbances in young kids that may persist later in childhood or an adolescence or even in adulthood. So for the first 5 here, so anorexia, bulimia, binge eating disorder, ARFID, and rumination disorder, they actually are mutually exclusive. So meaning during a single episode, only one of these disorders or diagnosis can be assigned. The rationale for that approach is to, despite us knowing that there are some similarities in terms of psychological and behavioral features, they actually differ very much so in the clinical course, the outcome, and treatment needs. And then PICA actually can be a diagnosis or can be present with other of the feeding and eating disorders. So one way to reduce the frequency of the unspecified diagnosis, so ARFID now replaces and extends the old diagnosis. So the goal is, hopefully, as we're making, as we are better recognizing our affected patients, we're able to have a specific diagnosis that now has clinical utility. So let's move on to the DSM-5 diagnosis of ARFID. So as mentioned, there is no age requirements because we know that this can even happen after. And again, we now are able to make the diagnosis even for older patients. So the main diagnostic criteria for ARFID would be, so this would be our criterion A, and it really has something to do with that avoidance or restriction of food intake. And what happens, they manifest having clinically significant failure to meet requirements for nutrition or insufficient energy intake through oral intake of food. And one of the following, so one of the 4 listed here, must be present. So 1 or more. So meaning someone who might come to you for a significant weight loss, who, especially for the population we serve, if they haven't completed growth or they're failing to meet their trajectory developments. And then if there's significant nutritional deficiency that can impact their health overall. And typically this is where it's important to assess for their dietary intake, do a physical exam, and do some adjunct workup. And then what's really, I guess if this does come out in the boards, since it's a diagnosis that's been out there for a good 7-8 years now, if they specify a patient who only relies on enteral supplementation, that would be most likely ARFID. And then lastly, like all of your other FEDs, those who have marked interference with psychosocial functioning, meaning they're not able to eat in a social setting, it just increases their anxiety, makes them restrict more. And some of these patients, as they get older, have difficulty sustaining relationships. So the rest of the criteria here is really more talking about where ARFID cannot be made as a diagnosis if, for one, there's food insecurity. So that will be our criterion B. So that's why we should be asking that and screen them at least once, every year. I know we do so for every wellness visit or for new patients. Or if it's because the restriction is due to cultural or religious practices. So for example, during Ramadan, our Muslim counterparts might go on fasting, or think of like your typical developing kid. So like my daughter, whose picture you saw earlier, she's now 3.5, very picky. So not unusual for toddlers, as opposed to someone who will be older, then you would probably think about ARFID. And the disturbance should not really be explained by excessive concern about body weight or shape, like in anorexia or bulimia. And also it should not occur in the context of another condition or disorder. Okay. So this actually I took from a presentation by Dr. Bryant, who is a clinical psychologist in Britain, and she's done a lot of good or extensive work in eating disorders, particularly in young children. So this diagram nicely summarizes what we just talked about with a diagnostic criteria for ARFID. So again, that one in highlight in red would be the main diagnostic feature of ARFID, meaning the avoidance or restriction of the food, and eventually leading to the ones in your oval-shaped with the weight loss, nutritional issues, supplementation, and then the psychosocial impairment, and then everything else in the blue boxes, that's when it should not be in presence of that. So in short, ARFID. So ARFID captures the key clinical features of, again, avoiding or restricting food intake, but without the distorted cognitions about weight and shape. So let's talk about atypical feeding and eating disorders. So back in 1992, Lask and Dr. Bryant, the clinical psychologist, they have found several eating disorders that occur in childhood. And unfortunately, it doesn't necessarily meet the criteria for someone with anorexia, again, because they don't have that body image concern. So 10 years later, they had created this classification system where they have these following 4 disorders related to food or restriction. So the first one, with the food avoidance emotional disorder, these are kids who they have a primary emotional disorder in which food avoidance is a prominent feature. And then your selective eating or eaters would be those who just eat very few different foods and sometimes are just very particular about the brand of food. So think of like someone who only likes to eat peanut butter, but it has to be like Skippies. And then someone who might have functional dysphagia. So these are the kids who have fear of swallowing, vomiting, or perhaps choking. Makes them anxious and resistant to eating normally. And it can also happen in someone who might have witnessed someone choking. And then lastly is the pervasive refusal syndrome, where this can actually be very life-threatening just because they refuse to eat, drink, or even do other of the normal activities of living. And it may last for months at a time. So with this classification, fast forward, we know that these are the ARFID kids that we're seeing. And again, none of these have that body image concern. There's no desire to lose weight. And they, with any of the disorders, they do fail to meet their nutritional needs. So it's not official yet if you look at the DSM-5, but there has been talks about specifying the subtypes. So there are 3 subtypes. And the first one would be your ARFID limited variety, or those who are just very sensitive or have sensory sensitivity issues. So these are patients who have long-standing feeding issues, typically present early in life, and there is a genetic component or biological factors that may put them at risk for developing this type or this subtype. They have, it depends also on what foods are available or what they were exposed to. If, again, social modeling, depending on like how the family eats or their parents, and then depending on the individual temperaments. So typically when we talk about sensitivity, often we should be asking, is it sensitivity to texture, temperature, how it smells, how it looks like, how it tastes. One speaker to talk about ARFID also that I attended talked about these are the patients who even as a young, like a months old baby, as they're starting to feed, if they feed something like, for example, peas, if there is that look of disgust, like, you know, with the first taste, most likely that kid would not want to eat that or might have some sensory issues. Then again, that's only one type of food. And I guess the more that you see that sort of look of disgust and presenting us with that, not liking that food. And I know as pediatricians, we do always encourage parents, guardians to keep feeding, even if they don't like it. But for those who have done work in this field, there's a certain sort of understanding that that may lead to that. And then also under this group would be those patients who have food on the plate and they don't want their food touching. And then the second one would be your ARFID limited intake, or those who don't have any interest of eating at all. So this also happens early in childhood. These kids might tend to be seen for failure to thrive. They just have very low overall appetites. They rarely get hungry. They have difficulties even with the physical act of feeding. So, you know, as parents, our knee-jerk reaction is to feed your kids, spoon feed them. But as time passes, it actually is an issue. Like they don't want to like lift a spoon or, you know, certain things that they're very particular with. So they tend to just eat small bite sizes. It takes them forever to finish a meal and they just get so full very easily. So these kids or these patients would come in with weight loss, unfortunately, maybe medically compromised to begin with and might end up in the hospital. And then your last group of patients, which would be your aversive type, these are the patients classically would have some sort of choking events. So what happens is there was something that had happened that resulted in a specific, like them being very specific with, you know, their anxiety, could be like perhaps fear of choking or even contamination. So I remember I had one patient who had, I think, some Slurpee or whatever at a gas station, and, you know, totally normal kid until having that Slurpee and had very bad diarrhea. And since then, don't want to eat out, which nothing crazy. However, that sort of led to the patient being very, very restrictive to the point that the kid was losing weight. Okay. So let's talk about prevalence. So these are the sort of the earlier studies and gives us an insight of what ARFID is all about. And we might be missing these patients in our practice. So, you know, one of the first investigations they did on the prevalence, looking at early onset restrictive eating disturbances, was done at a non-clinical setting. So in this primary school setting in Switzerland. And so out of this, how many number of middle school students around ages 8 to 13, they had found around 3% of students who did report having features of ARFID. And this is based on self-rating. So of the 46 students, majority of them did have sensory property issues, had no interest of eating whatsoever. And then around 15% of them, so 7 students, has had that aversive negative consequence of eating. And then when they looked at how many students, at least 7 has had at least 2 of the eating disturbances mentioned. So what we also noticed as we're looking at their numbers, underweight children reported features of ARFID significantly more than normal weight kids. And the normal weight kids had reported features of ARFID more so than overweight kids. So it just tells you ARFID kids tend to be on the low weight status. And then in clinical settings, based on earlier studies, so the first one, they looked at adolescent medicine specific institutions, and it sort of ranged from 12 to 14%. And these were all like outpatients. And then in a pediatric tertiary care hospital in Canada, they actually had around 5%. So these were your inpatient patients. And then for those who were admitted for refeeding, out of their population of 215, so in Cleveland Clinic, they found around 13% had met criteria for ARFID. And then one of the studies coming out from a subspecialty clinic, particularly the Peds GI clinic, where they actually had looked at more than 2,000 patients or medical records and found it might be a small percent, but there's around 1.5% of those patients who met all criteria, where around 2.4% have met at least one of the ARFID criteria. So this is one of the studies from that adolescent medicine sort of consortium. So what they had found, so as mentioned, they have around 14% identified as having ARFID. So what they found that patients with ARFID were younger than those with anorexia or bulimia. And then the other one notable was that the median body weight was sort of in between anorexia and bulimia. And then ARFID patients had a longer duration of illness, and they were more likely to be male. At least half of the patients were actually referred by their primary care physician or provider. And then 10% were patients seen in the ER, and then 10% were actually referred from a mental health person or provider. And then the other thing notable from the study was patients with ARFID were first more likely to have a comorbid medical condition. So hence many of them would be seen by a specialist and have had some extensive workup. They're also more likely to have an anxiety disorder. So as you can see, it's significantly different, but they are less likely to have a mood disorder like depression. So more on the same study. So when they looked at the ARFID population, around 28%, 29% were selective or picky eaters since early childhood. And a good portion of those patients also had generalized anxiety, GI symptoms, and 13% of them had fears of choking or vomiting. And around the same number of percent were just restrictive eaters for other reasons, which they didn't really specify. So now shifting to the inpatient setting. So this is the one study out of Cleveland Clinic, and they are the first to assess the inpatient ARFID population. So from their end of 2015, around 13% were found to have ARFID. And what they had noted as they're comparing to patients with anorexia, these are patients who tend to be younger. Although the age of 16, their explanation was it likely was because their study population was actually, I believe, ages either 8 or 9 till 30. So perhaps that's where the age 16 was coming from. But they tend to be younger. They actually came in with a shorter duration of illness compared to the first study, although that was more outpatient. Probably those patients had seen different people by the time they saw the specialists. And then they typically have less weight loss prior to admission. Because often the younger kids, it's not about the weight loss, it's more about them not able to gain weight. And they actually had lower percent of expected body weight illness compared to with those admitted for anorexia. And then ARFID patients were found to have fewer traditional eating disorder behaviors. So we're talking about like, dieting, looking at calories, purging, and things like that. And they're also, ARFID patients are actually fearful of vomiting and abdominal pain. And other thing to note that the last portion of the results table, likely less likely to have a family member with a psychiatric or eating disorder. So during admission or hospitalization, what they've seen are like ARFID patients were less likely to be bradycardic, but they did tend to stay longer inpatients. And they actually had the same caloric intake compared to the anorexic patients. But more so, they did rely on enteral supplementation. So these are kids who either ended up getting a tube, an NG, or an NJ. But despite the differences in course of illness and hospitalization, ARFID and anorexia patients had similar outcomes 1 year after initial admission, and no significant difference in readmission or remission. So this one, it's actually an important study because it's the first to actually use the diagnosis of ARFID and admit a patient with that diagnosis, as opposed to going back and looking at how many would have met the ARFID diagnosis. So this one, they looked at patients admitted from 2013 to 2016. And what they saw was of the 369 patients, 31% of 31 or 8% had ARFID, 2/3 were under the age of 12. Almost half of them had been evaluated for eating issues in the past. And then the one boxed, the main thing to show here is that weight loss or failure to achieve appropriate weight gain was the reason for diagnosis, except in one patient. And then majority had reported the specific trigger for their eating disturbance. So admission for inpatient hospitalization occurred in more than half of the patients seen. Okay. All right. So general conclusions, what we have so far, and there's more that's actually coming out, but pretty much always would refer back to the studies that I showed you. ARFID patients are younger. In general, females are likely to have an eating disorder, but when it comes to ARFID, there's actually more males in that category compared to the other eating disorders. And then they tend to be underweight compared to your anorexia patients. As mentioned, they have fewer typical eating disorder behaviors, most likely to have a medical comorbidity and anxiety, and then less likely to have depression. So the typical patients I see in clinic is exactly this. Not exactly this, but as a majority, it's usually like when I see in the referrals an 8-year-old, I'm almost always sure it's something about ARFID or picky eating. So it's usually an 8-year-old male who has anxiety and has had some sort of choking. But it still continues to be a diagnostic challenge. And that's why I think it's an important topic to talk about, because you might be getting in families who are saying like, my kid just never eats, it's just so picky. And then you might need to really delve into like their nutritional history and then, proceed with your workup, vital signs, growth chart, and all that stuff. And then thinking, is there anything like a compromise in their health that I need to be assessing for? So ARFID can coexist with other conditions. So listed on the left are all of your psychiatric disorders. On the right, or I guess, yeah, on your right, yeah, medical disorders. So, so patients who, and I've had patients with ADHD and are on stimulants, it actually makes it difficult to manage these patients just because the stimulants will bring about the appetite suppression. And then you're like, you need to eat, but they just don't have an appetite, right? And then I probably have a couple of patients that I saw, one inpatient, one outpatient, who came to me and was told they have PANS or PANDAS, or as you can see, not these types of PANDAS, but their pediatric autoimmune neuropsychiatric disorder after having strep infection. So these patients can present with acute food refusal. And we know there's reported treatments of like antibiotics, anti-inflammatory medications, IVIG, but it's, as you know, it's complex to manage these patients because there's that neuropsychiatric part and then the medical component as well. So meet Sheldon Cooper, one of my favorite shows, and I actually haven't watched the young Sheldon as much yet, but I'm just gonna show you a short clip to sort of just summarize and give you how it looks like when they present to us. So let me see. Can you see the video? Can you see the video? And I don't have
yes. Yes, we can.
Okay, so let me.
What aren't you eating?
I don't think I can.
Sometimes the different foods touch each other, Sheldon. Not the end of the world.
Oh,
No,
wait.
I'm afraid I'll choke again.
Oh,
Sorry, can you see it?
So we can see the web browser, but I'm assuming there's a video that's full screen.
So let me stop share and then share the video when I share my screen. I think that's how. I think. Here we go. Do you see it now?
I believe that's working.
Yes. Let me...
Hey, that's not going to happen. What aren't you eating?
I don't think I can.
Sometimes the different foods touch each other, Sheldon. Not the end of the world.
No, I'm afraid I'll choke again.
Oh, honey, that's not going to happen. Go ahead, eat your dinner.
What's all this about choking? Sheldon almost died this morning.
What?
Oh yeah, Dad was shaking him upside down like a ketchup box. It was great.
Well, you got to eat something, baby. Just have a few bites.
I can't. It's too risky. Dibs on third dots.
All right, I'll wrap that up for you. And if you change your mind, you can have some later. At least drink your milk.
Sure.
My mother and father saw that I'd been traumatized and were patient and understanding about my fear of eating solid foods. This lasted one more day.
Sheldon Lee Cooper, if you don't finish that pork chop, I swear I will chew it up and spit it in your mouth like a mama bird.
Do it, Mom. Do it.
Mary, can I speak to you for a second? No, enough is enough. The boy has got to eat. Just give me a minute. Start eating, mister.
So let me share my slides again. All right, I think I am back where I should be. Okay. So I showed you that video just because I am, and this is something you also see, and we know patients with autism spectrum disorder, and we know they are neurodevelopmental disorders, and they have impairments in communication, social interactions. They have repetitive behaviors, and for a fact, we know that they also have a lot of sensory processing impairments. So with all that, feeding difficulties are common in kids with autism, and one study had even estimated it to be close to 90%. So typically, the sensory issues would be those who would have issues with texture, over appearance, over taste, over smell, over temperature. And because they already have challenges in social settings, it even makes their eating difficulties more problematic. And some of the eating and oral behavior problems include rigid eating behaviors, such as those who, what do you call this? Like they are so afraid to start or try new foods. They cannot eat a different brand of peanut butter. Just many of those rigid rules. And what's important to note is that not all kids with autism will develop clinically significant feeding and eating disorders. And the same way, someone who has ARFID doesn't always mean that they have autism. But I've had a couple of patients that I did refer for testing, which you would hope if there was autism would have been picked up before, but we do know that sometimes it can be missed or may not be as obvious. And then it's only really when they would have compromised with their health, that they would need treatment, that would say with the ASD and the ARFID, we need these patients to be seen right away. And then prevalence of ARFID in children with autism significantly higher than those who are typically developing children. So reasons for referrals. So who gets referred? So this is just a short list of what I personally had seen in practice. Abdominal pain is almost always there. And I always ask about choking or anything traumatic that may have happened that may have led to like changes of their eating or restrictive eating. I had one who thought, and she has anxiety, but she thought she had choked on lettuce, and then since then don't want to eat lettuce anymore and other things similar to that. They probably have 3 patients who it's almost always Thanksgiving, right? Someone almost always chokes on turkey for some reason. And then I've had patients referred to me by their therapist with their anxiety, and it's just impacting their feeding so much. All right, so this also again is from Dr. Bryant, who is that clinical psychologist in Britain. And this is helpful. Probably this is one important slide that will help you ask the right questions and know why you're asking those questions. So typically asking about what they're able to eat, their current range, has there been a change? And then the main thing also is how long has this been going on? Because if it's like mom is like, oh, he stopped eating peanut butter. And I always say peanut butter because I hate to say this, but I had a couple of patients that for me to remember who's who, because one preferred like the chunky peanut butter, one opted like the smooth one. But peanut butter is almost always something as well. If they haven't eaten peanut butter like in the last week, mom's super worried, you probably would need to ask more, as opposed to someone who has had issues for a long, long time. And then you need to look at the growth chart because the purpose of that is to help identify, is there weight loss? Are they not just gaining weight, or are they stunted? And then looking for any deficiencies, any malnutrition, using your clinical eye, but also doing blood work if you need to. And then almost always they rely on supplementation. So I've had patients who would only drink 2 supplements a day, and that's pretty much it. Which, yes, you're getting your calories, but we know that's never enough. And then the main thing, so if you remember criterion 8.4 is about the psychosocial distress, because now you really need to get the help that they need right away, because if not, they are going to be struggling with not only medical, but also psychological later on in life. So the main question I get when I get these referrals would be ARFID versus anorexia. And this, sort of nicely differentiates the two. So ARFID is afraid of the process of gaining weight, as opposed to anorexia, they're afraid to gain weight. And then ARFID tends to avoid lower calorie foods for whatever reason. And I have patients who only really like to eat a lot more like carbs and afraid of like the other nutritional stuff, as opposed to anorexia, they just avoid the opposite. And again, there's that weight concern, body image concerns with anorexia. And then the age difference, younger in ARFID, older in anorexia. And then gender-wise, more common in males in ARFID as opposed to anorexia. And then ARFID, they're more impulsive. They have less self-control as opposed to anorexia. They use their very last ounce of energy from the very minimal food that they eat, and they're still able to self-control excessively. So this picture here that I'm showing you is actually an ongoing NIH study out in Boston. And it's nice looking at choosemyplate.gov, which I love this website, it's telling us that their preliminary data is showing what we are seeing, like ARFID patients tend to eat more grains and less protein. And then I just sort of found a similar picture of a plate for anorexia, again, to just highlight that component that there's nothing on their plate and it's all about the weight and they worry about the numbers. So a bit of a busy slide and a lot of words, I know. But the point is there's no currently there are no validated assessment tools for ARFID. However, you can use the ETSU, which it actually looks at 8 different subscales, including questions on purging, restriction, some negative attitudes towards weight. And then your EDYQ is actually the self-survey questionnaire they did in one of the first studies I mentioned. It's actually helpful because it does have those specific questions about emotional food avoidance, selective eating, restriction, and any aversive or fear to any aversive consequences when they're eating. And then the rest are all validated, but not for ARFID. So when you see these patients, as like any other patients, you would need to do a thorough physical exam and more so assess your pubertal development. And many of these kids may come in pre-pubertal, not showing any signs of puberty yet, and they're sort of at that age where they should be showing those signs. And then this is just a list of blood work, which you probably know, majority of these patients end up having normal blood work, but it's always nice to get baseline because you never know if it's actually going to get worse under your care, and then you might need to eventually admit them if that's indicated. So how do we manage these patients? I always say it takes a village. So yes, I may be seeing these patients, but I'm only one component of the treatment team. So I always say we need the whole group, the whole village. So from the medical standpoint, nutritional standpoint, and psychological interventions. But what's important is setting realistic goals with families and the patient. So meaning it's not realistic, someone who's only eating, let's say 20 things, and they can list the 20 things that they eat. And then you're like, well, by next month, we should double that. It's going to be very, very difficult for the patient to do that. But we know that weight gain is needed, must be done, and not eating is not an option. And then need to assess how bad or how sick they are. Because if they are sick enough, they need to be admitted, or frequent follow-ups outpatient, or if they might need to do further workup if you're worried about the consequences of the malnutrition. And then most importantly, addressing that impairments from a social and emotional standpoint. So the medical monitoring part, so I've mentioned about gaining weight, because you want them to start their trajectory in puberty developments. So someone who's stunted with height, low weights, again, delayed puberty, nutrition alone can help proceed with that. And then when you see them, the question is this outpatient management? Is this inpatient management? And I'm fortunate when I joined our school here, we already have an existing eating disorder protocol, which ARFID patients can be part of. And of course, addressing if there's any comorbidities with that patient. So this is from Golden and friends or co-authors. But this is also the criteria we use for patients who come in for malnutrition and also for eating disorders, particularly anorexia. But anywhere if they have any physiologic instability or anything here, particularly the acute food refusal, there is it is warranted for them to be admitted for medical monitoring. The question I always get is, do we or should we start medications? To be honest, there are no FDA-approved medications for ARFID, and only very few for eating disorders in general. So thinking of anorexia, there's actually no medications for anorexia, although there are some that are, in the process of being FDA-approved. But what we know, like Prozac or fluoxetine is useful for binge eating disorder. And then Vyvanse or lisdexamfetamine is Prozac is for bulimia nervosa, and then Vyvanse would be for your binge eating disorder. So those are like FDA approved use. But there had been some case reports. So someone we had put on Buspar or Risperidone. We know that it helps treat symptoms of pharyngeal dysphagias and esophageal motility disorders. So in this one, it was a 14-year-old with anxiety and had repeated bouts of vomiting and abdominal pain, and then they treated with Buspar. And then the second one, mirtazapine Remeron or mirtazapine they are actually after the side effect of weight gain and promoting appetite. So this was used in, I think there were 14 patients in this study, and it did help facilitate weight gain. And then the other one is olanzapine, where it's for adults mainly. It could be efficacious for those with anorexia, but it's more so to help patients again with weight gain, promoting eating habits. But what helped was also treating the comorbid anxiety, depression, and cognitive impairment. And then what about risperidone? It's an atypical antipsychotic. We know weight gain is something that can happen, but this was from a study. They looked at 2 young patients. They were actually treated with risperidone while inpatient, and it sort of helped reduce their ADHD and ODD symptoms. And again, with that side effect targeting weight gain and the appetite stimulation, it did help. But as you can see here, patient really needed that outpatient therapy. So nutritional advice, again, it's someone that I would need the expertise of our registered dietitian. But it's talking about everything about balance. But this one is very important to do hand in hand with the psychological interventions, particularly if you're working with a speech pathologist or an occupational therapist. But nutrition does help a lot, especially giving some tips, ideas, especially if a kid, let's say, only eats, used to eat apple, doesn't eat apple anymore. So you can slowly introduce by, saying, well, you can try like applesauce or different preparations and things like that. And if in the hospital, then you would need their guidance as you feed them entirely. And then I'll just mention here, CBT is a big one just because anxiety is found to be very high in these patients. But for your young patients with selective eating, they mentioned about systematic desensitization, where the patient needs the repeated exposure to new foods through play with no stated expectation for consumption. So just like play therapy, as opposed to operants conditioning, where you are actually giving them rewards. So the therapist will do that, or the caregiver, when they consume the target food. But I've had patients, they will go to bed without eating, even if they are hungry or not hungry and not eating at all, if you keep serving the food that they are worried about or scared of. And of course, you have your alternative approaches. I did mention about speech and occupational therapists. So this is one form of therapy. The point is you would encourage the patient to identify and challenge the negative thoughts that interfere with their ability to try new foods. Sometimes push them to eat until they get uncomfortably full. The idea is you want to expose them to the hierarchy of different foods and situations. So for example, French fries and ketchup, probably start with that one and eventually progress to like dipping sauces, or maybe try French fries from another restaurant or another way of cut, or maybe hash browns or tater tots. And then again, incentives are, giving incentives have been thought to help modify these behaviors. And then something that's relatively not necessarily new, but there's more and more studies or more, I guess, group of researchers looking at the specific CBT for ARFID called CBT-AR. It goes through 4 stages as listed here. I mean, the main goal at the end is that they no longer meet the criteria for ARFID. They're able to expand their eating repertoire, and then, if they did have any nutritional deficiencies, you're able to correct them. There is a patient and family workbook that you can Google, and it goes, it shows there what parents need to do per stage. The main thing also, again, depending on how severely underweight they are, it could be many sessions, as like 30 sessions, but they need the commitments, and parents need to be on board for it to work. And then family-based therapy is the one that we know is evidence-based, and we use a lot in anorexia nervosa. where you empower family members, you give them the education, you tell them, don't feel guilty, this is not your fault. You remove the anxiety that goes along with the dynamics in the family. And then you say that the eating disorder is the enemy. And then, so the monthly approach with the family-based therapy, the first part is you have the parents in total control from everything from purchasing, planning, prepping the food, plating, things like that. And this has worked and truly works for anorexia. And in this study, this is a series of patients actually, but this one particular case they described in an almost 11-year-old girl. Parents are actually professionals. They have, there's a younger sister there. But this kid started out having, well, already is an anxious kid to begin with, always complains of stomach ache and no medical cause known, doesn't want to go to school, but despite all that, doesn't really have eating problems or growth problems. But would have these repeated episodes of viral gastroenteritis, which made the patient convinced that if she eats, it brings about the infection. So she stopped eating, ate less, lost weight, eventually got admitted. And then parents, in the process were also trying to eliminate foods they thought would be exacerbating the symptoms. So in the growth or the chart here, so the patient was admitted, was around 75% of her target weights. And then the next line, after 1 month, patient's weight barely increased. And so they got the ED team and they started family therapy. And as mentioned in the previous slide, they tried to empower the parents, despite parents thinking that it's a medical problem to begin with. They help explain that it's important to eat and that not eating is not an option, even if there's a lot of arguments when they're eating, because the only way out of this disorder is to nourish the body, gain the weight, and it will help with everything else. So fast forward, this patient also got some medications like olanzapine and Prozac, which help with some of the anxiety symptoms. At the end of the family therapy, patient was discharged, as you can see there, at a good weight, and actually was able to maintain 100% of her target weight. So just highlighting that family therapy is very important, and there's success to this. Okay, so I'll just share a couple of the patients I've seen. So this is the first patient I've ever seen that I made a diagnosis of ARFID. And interestingly, it's the first patient that I saw in Mississippi, was admitted. He also was an undiagnosed in terms of does have some cognitive impairments. Later on, psychiatrists deemed the patient was on the spectrum. But the story was younger brother who was typically developing, normal kid, got admitted for stomach ache, and that made my patient scared. And since then, the patient did not eat. So literally only had some sips of water for 3 weeks, got admitted, I got consulted. The hospitalist said, oh, the patient's eating, let's send the patient home. And I'm like, sure, why not? But anyway, they saw me outpatient. Of note, the mom has anorexia and it's not in the picture. But this patient, during at least the 2-3 months I was following him outpatient, and a grandmother was actually helping out the dad, because the dad is a single dad. And just boost alone, we're able to get the weight up, as you can see here. At least he's in the growth chart, right? But he was lost to follow-ups. I don't know what happened, but we were planning to treat him for anxiety, and he disappeared. So the next patient I saw, one of my next patients, which I would say is a success story I had in Mississippi, because I was able to follow her until she really got better. It's a very anxious kid. Workup did show low ANC, low vitamin D, and low iron from being very picky. She was just very limited with what she would want to eat. I saw her every week for a weight check. I got a dietitian involved. We did sort of a modified family-based therapy, which was hard because we need an expert to do that with us. But what I feel like really helped is I got psychiatry involved. We put her on Prozac. We added Abilify, which eventually, helped promote the weight, and weight alone I mean, she also started eating more. And one of the success was she started drinking some Starbucks, this one, which I think it's a frap, what do you call it? Unicorn frap, which I don't know, 600, 700 calories. But she's also not opposed to being on an appetite stimulant. So we had her on a combo of Prozac, Abilify, and Periactin, and she did very well by the time I left Mississippi. And her growth chart, so happy. And I think she was starting to develop, like telarchy was happening. And then this is one of my first patients here in Kalamazoo. Long story short, by the time I got him, he's had a full workup from GI, chronic abdominal pain. His weight was just going down. He actually ended up in a residential place. When he came back, he was not happy. Not happy of the experience, but happy that he gained weight, which is not typical of your anorexia patients. Had him see psychiatry outpatient with me, but he was just a difficult patient in general. He has a different temperaments. I also think he's on the spectrum, has ADHD, and the ADHD treatment was a bit like challenging because I don't want to suppress his appetite. But the last time I saw him, I think he was already 18 by the time he disappeared also from me. He always remained in the 100 to 103 pounds weight-wise. But as you can see the growth chart here, the first arrow is when he got admitted, second arrow is when he got tube fed in the hospital, and the third arrow is when he got out of Rogers. And lastly, I had a recent consult on a 19-year-old patient. Her presentation was nausea, postprandial pain, vomiting, diarrhea, found to have a duplication of her congenital gallbladder, which was removed. Was okay for 3 months, but then symptoms came back. The most she ever weighed was 103 pounds, but at the time she was actually pregnant. So yes, interestingly enough, she was at a good weight to actually ovulate and get pregnant. So that's if you see in the growth chart, one of the higher dots there. It was only a 2-3 day admission hospital stay, because we got the NG placed and she said the pain was gone, but of course it's temporary because she cannot have the tube forever. But having the tube helped her eat while in the hospital, and then she got discharged home. And I feel like she really fit the picture of ARFID. And I'm just gonna mention one thing about COVID. It is true. So I went on maternity leave last year, came back December, and my clinic, I was seeing like 3 new ED patients every week. And if you had worked with adolescent medicine, our notes are pretty long. My residents have told me I should start dictating my notes. But anyway, a big surge during COVID, especially anorexia for sure. But the ARFID kids, what happened, interestingly, my observation, I haven't been seeing a lot of ARFID kids during, and even, now that we're seeing more and more of them, but something to do with anxiety. So many of the restaurants they used to eat out are closed now. They, their comfort food and things like that. So there are patients, and NIDA, the National Eating Disorder Association, actually has had an uptick of calls from patients. So, so in conclusion, well, not really new diagnosis anymore, but it's nice that you guys haven't had this talk yet. But we need to know about ARFID, where people are still interested to find more information about it. No validated tools, but what we know works, at least, would be family-based therapy and also your multidisciplinary approach. And my resources and questions. Thank you again. Let me see if there's anything in the chat.
Thank you for that talk. That was really interesting. I was just going to ask, in y'all's clinic, do you do anything differently for these patients, like integrated speech therapy, or like in terms of the clinic setup itself, that you feel like is helpful?
Yeah, I mean, I wish I had our own OT, but we have a different setup here institution-wise. But I've had patients that I had them see an occupational therapist, because they actually do. So since they're younger, a lot of anxiety, and many of them prefer like play sort of therapy. I've had a couple that did do well with OT, and then with COVID, everything just shut down, so it was hard to do that integrative approach. The most that I probably do with these patients with my current setup is having a dietitian come in. And then sometimes we have integrated behavioral health help us out with some anxiety issues. But if they know it's a clear-cut eating disorder, our psychologists, because they're not trained to do that, they don't really participate as much. But it'll be nice because I know with the bigger centers, they actually have that integrated all of the other subspecialists involved.
Thank you. Yeah, that's really a challenge we've run into with other restrictive eating disorders. Is just kind of building integrated care, and then all of the eating disorder specialists around Johnson City are more or less a few hours away. So it's just hard to coordinate sometimes.
Yeah, and I know there's more and more looking at the value of telemedicine. I think it works a lot for those who don't really worry about the numbers and the scale and things like that. And some of these kids, you do need to have them come in, and even if it's their primary care physician being able to see them, at least to assess and see how bad they are. I mean, the goal is hopefully to prevent these kids from being in the hospital, but unfortunately, because there's not enough of people interested in this field, or it's too much, it's too complex, to be honest, some of these kids do end up in the hospital.
Definitely sounds like a challenge. So
Yeah, for lack of a better word. Well, I hope it's helpful. But thank you again for the invitation. And I forgot to add my email, but I'm sure Dr. would, or can share my email for those who are interested in more about the topic or have any questions for me. So hopefully you enjoyed your lunch hour. Yep, these are my two kids. One is turning almost 4, and then the other one is 9 months old now. So, all right. I don't see the chat, so I don't know if someone's putting anything there. I'm trying to find my chat here.
No, it looks like no questions.
All right.
So.
Well, thank you. Thank you so much, and have a good rest of your afternoon.
All right. Thanks, Dr. Cabral.
Bye.